I am pleased to introduce our second plenary talk, and it's a joint presentation featuring Dr. Penny MacDonald and PhD candidate Maggie Prenger. Dr. MacDonald is a movement disorders neurologist, Canada Research Chair Tier 2 in Cognitive Neuroscience and Neuroimaging, and Associate Professor in Neurology in the Department of Clinical Neurological Sciences at the University of Western Ontario. She is also a principal investigator at the Brain and Mind Institute. Dr. MacDonald obtained a PhD in experimental psychology from the University of Toronto under the supervision of Dr. Colin MacLeod prior to completing medical school at McMaster University and residency training in neurology at McGill. She pursued clinical and research fellowship training in movement disorders as a Canadian Institutes of Health Phase 1 clinician scientist at the Montreal Neurological Institute and the Centre de Recherche de l'Institut Université. Sorry, don't speak French. I can skip that. She evaluates and treats patients with a variety of movement disorders with a special interest in Parkinson's disease. In addition to attending to movement-related symptoms, she's interested in improving the diagnosis and treatment of cognitive impairments in movement disorders. Her long-term research aims are to uncover neural bases for cognitive processes, and the research involves probing different facets of cognition with a variety of neuropsychological tests. Performance on these tests is correlated with levels of activation in different brain images and is assessed with different brain regions and assessed with functional neuroimaging. Further objective is to develop more precise cognitive profiles of various movement disorders with the overarching goal of improving diagnosis and suggesting more effective treatments of cognitive impairments. Maggie is an MD PhD student supervised by Dr. MacDonald and Dr. Adrian Owen at University of Western Ontario. She completed her Master's of Neuroscience in 2020 at the University of Western Ontario. Her research focuses on the social symptoms of Parkinson's disease that can arise due to the degeneration of dopamine neurons in particular areas of the brain. For her PhD, she is currently investigating the presence and nature of, I've got humor processing deficits. Wow, humor processing deficits in Parkinson's disease using functional magnetic resonance imaging techniques. How interesting. Please join with me in welcoming the two of them to the stage.
Thank you so much for the lovely introduction. Hello, everyone. Today, Dr. MacDonald and I are going to be discussing the various social symptoms of Parkinson's disease and talking about how these can affect the lives of patients and families. So we're going to dive into theories as to why these symptoms occur and some of the treatments that might be available. But overall, our main goal with this talk is to increase awareness of these symptoms because that is the first and most important step that clinicians, patients, and caregivers can take to help mitigate the negative consequences that these symptoms can invoke. So, the motor symptoms of Parkinson's disease are the most well-characterized, most well-researched, and best acknowledged symptoms of the disease. However, it's becoming apparent that there are a whole host of non-motor symptoms associated with Parkinson's as well, such as cognitive, autonomic, and social symptoms. However, compared to these other symptom groups, these social symptoms are the least well-studied, least well-recognized. However, there's evidence to show that they have the greatest impact on quality of life compared to these other symptom groups. So there are many social symptoms that patients might or might not experience throughout the disease course, and I'm going to discuss these today. So facial masking, which is also known as hypomimia, involves reductions in the ability to express emotions on the face. So this includes reductions in the intensity and the size of facial movements, as well as the frequency of these emotional displays. So in this example here, you can see that some patients with Parkinson's disease on the top panel have greatly reduced facial expressions in response to painful stimulation compared to the healthier controls shown here on the bottom. So importantly, facial masking does not influence the ability to experience emotional feelings. It's just a problem with displaying the emotion on the face. So this is demonstrated quite nicely in a quote from a patient's spouse. "It's interesting. He can be really upset and his face wouldn't tell anything. You know, it's that sort of real deadpan face. You know, he can be saying the words, but the face doesn't tell. It doesn't tell anything." So there's also evidence that this symptom can occur more often and more severely during negative social contexts. So for example, during an argument or during when you're discussing something frustrating. And that's really a shame because that's one of the most important times that these facial emotional displays can help convey how someone is feeling. So, another symptom involving emotional facial expressions that some patients experience is difficulty recognizing the expressions of other people. So overall, research demonstrates that there is an impairment here, but there are discrepancies about whether this is a global impairment that affects the recognition of all facial emotions, or whether it's specific to particular emotions such as fear and anger. And there's evidence that difficulty recognizing the emotions of other people is worse for patients who are more progressed in the disease, as well as those who experience cognitive impairment. So dysarthria is another social symptom. This involves producing speech that is grammatically and syntactically correct. So the content of what someone might be saying is totally fine, but the speech is marked by abnormal rhythm, a harsh voice, inappropriate pauses, and prosodic loss. So this is a waveform of a 70-year-old female patient with Parkinson's disease repeating the word P 15 times. And you can see that over time, the produced sound gets less intense and quieter. So approximately 90% of patients with Parkinson's disease demonstrate some sort of deterioration of speech, and 30% of patients report this symptom as their highest concern above all other symptoms. And then importantly, this symptom can contribute to social isolation and withdrawal because patients find it difficult to participate in conversations. So this is a quote from a female patient with Parkinson's disease that's particularly striking. "At one time, I could keep a conversation going for ages, but I can't now. I just sit back and listen." So I briefly mentioned prosody in my discussion of dysarthria. Prosody refers to the rhythm and intonation used in speech, which gives context to speech and communicates emotion. So this is a fun example of how prosody can convey different contexts. So the word really can mean many different things depending on the prosody or how it is said. So for example, really? As in, how cool? Really? As in, I don't believe you. Really? As in, I'm shocked. Really? As in, I'm delighted. Or really? As in, I'm serious. So just as some patients have difficulty recognizing the emotional facial expressions of other people, some patients with Parkinson's might also experience difficulty recognizing these slight variations in prosody that can convey important meaning and emotion during speech. So some patients have difficulty recognizing all emotion in speech, but there's some evidence that negative emotions like fear and anger are affected to a greater degree. So there's also emerging evidence that Parkinson's disease can affect the ability to understand and enjoy humor. There's a reduced sense of humor has been associated to a higher disease severity. So what we see in this graph is that scores on a questionnaire measuring sense of humor tend to go down as UPDRS scores go up. So in other words, as the disease progresses, sense of humor is lessened. And as mentioned, this is what I'm currently working on for my PhD research. It's a really fun topic. And so far, we have found that when you ask patients with Parkinson's disease and healthy controls to categorize audio clips as jokes and non-jokes, the patients tend to erroneously categorize non-jokes as jokes more often. So on this graph, you can see that we're plotting accuracy rates, or percent correct, for both healthy controls and patients in their ability to categorize jokes and non-jokes. So we were expecting to find that patients would have reduced accuracy for the joke category, but we actually found the opposite. So this puzzled us for a little bit, but we did some further analyses, and we realized that the patient group had a tendency to choose the joke category more often, which of course would lead to a higher accuracy rate for joke audio clips and a lower accuracy rate for non-joke audio clips. So it's possible that the patient group is more liberal in categorizing things as a joke because they experience more uncertainty and expect the audio clips to be jokes based on the nature of the study. So this is something that we're currently looking into a little bit more with functional magnetic resonance imaging to look at brain activity during these judgments. So stay tuned for some more papers coming out within the next year or so. Theory of mind refers to the ability to have a sense of what other people are thinking, and this is considered to be an essential social and cognitive skill. One of the most common tests of theory of mind development in children is the false belief task. So this is Sally. Sally has a toy, which she puts in a bowl, and then Sally leaves the room. While Sally is gone, Anne takes the toy out of the bowl and puts it in a box. Sally comes back and wants to play with her toy. And the question is, where will Sally look for her toy? So most children under the age of 4 will incorrectly respond that Sally will look for the toy in the box because they haven't yet developed the ability to understand that Sally doesn't have the same information that they do and that the toy has been moved to the box while she was gone, instead of it being in the bowl where she originally put it. Another test of theory of mind, which is used more often with adults, is the faux pas test, in which a person is presented with a situation and asked to identify whether any of the characters said something that they shouldn't have. So this example here, there's a woman at a coffee shop who sees her friend. She says, "Ah, there you are." And the friend responds, "I am so happy to be leaving this place. I think this is the worst coffee in town." And then the woman introduces her friend to the third person who's there, who's actually the owner of the restaurant. So there is some evidence that patients with Parkinson's disease can have difficulties with faux pas identification and other tests of theory of mind. However, this might be limited to more advanced stage Parkinson's disease. As you can see in this graph here, plotting the accuracy rate of identifying faux pas. Patients with, in the earlier stages of Parkinson's disease performed comparable to the healthy controls, whereas the patients with more advanced Parkinson's disease had reduced accuracy rates. And theory of mind deficits have been associated with poor health-related quality of life, which emphasizes the clinical relevance of this issue. Mood disorders are extremely common in Parkinson's disease. This includes apathy, which is characterized by a loss of motivation, reduced interests, and emotional blunting. Depression, which involves sadness, fatigue, insomnia, as well as anxiety, which is characterized by excessive worry, restlessness, or racing a heart. Parkinson's disease involves these mood disorders at much higher rates than other chronic illness populations. And there's evidence that these mood disorders can interact with other symptoms of the disease. So for example, those with greater facial masking tend to have greater depression as well. But it's currently unclear whether one of these causes the other or whether they're simply both symptoms of the disease that present in tandem. And similarly, mood disorders are associated with social consequences like withdrawal and partner satisfaction. So, speaking of negative consequences, of course, all of these social symptoms can lead to negative social consequences as well. One of these major consequences is stigma, which is a negative perception that discredits or devalues an individual within social contexts. So, facial masking in particular has been identified as a large contributor to stigma, and because of this, it has a large influence on quality of life. So this diagram here shows that there is a relationship between facial masking and quality of life, but this relationship is better explained through a third factor, which is stigma. So in other words, facial masking leads to stigma, which then leads to decreased quality of life. So this is a quote from a patient interview. "The number one complaint my family has is that they say I always look like I'm mad. My left side of my face tends to freeze like a zombie type, and I can't talk sometimes, and they always think I'm mad or something." And another quote, this time from a caregiver, expresses negative feelings as a result of their partner's facial masking. "It's not only a mask, it's sort of like a blank stare, and sort of like having somebody stare at you can be quite uncomfortable." So one study asked participants to give impressions of patients with Parkinson's disease and healthy age-matched peers. And the participants in this study reported patients with greater degrees of facial masking to be less friendly, less intelligent, less optimistic, less attentive, and less attractive than their healthy controls. So overall, there's evidence that patients with Parkinson's disease are thought to be less socially desirable by the general population because of facial masking. And unfortunately, this effect is worse for female patients, perhaps due to societal expectations that women should be more emotional. There's also evidence that dysarthria leads to stigmatization. So this is a similar study in which participants were asked to give their impressions of clips of patients with Parkinson's and then healthy people speaking. So participants in this study rated the patients with Parkinson's disease to be less friendly, less happy, less involved, and less interested than the healthy controls. And importantly, this effect was not seen when the participants were asked to focus on the spoken content of the audio rather than on their impression of the speaker themselves. So dehumanization is another negative consequence of social symptoms of Parkinson's disease, and this refers to the denial of another person's agency and is unfortunately experienced in healthcare quite frequently. So modern healthcare settings typically require neurologists to assess and discuss all of the different aspects of Parkinson's disease, including motor, cognitive, and social symptoms, during appointments that are typically scheduled for 30 to 60 minutes. So in order to gain a lot of information in a short amount of time, clinicians often rely on nonverbal communication cues as a way of assessing how a patient is doing overall. However, this strategy is less likely to be effective with patients who have Parkinson's disease who experience significant social or communication deficits. There's evidence suggesting that patients with Parkinson's disease might take longer to communicate due to facial masking and dysarthria, and this includes in a clinical setting. So sometimes caregivers might take control of an appointment to try to provide the clinician with important information more quickly. And although this is effective at transmitting information, this approach can be detrimental because the patient might not feel as if their voice is heard. There's also evidence that clinicians can form negative perceptions of patients with Parkinson's disease as a result of facial masking and dysarthria, including judgments that patients are more depressed, less intelligent, and less sociable than patients without these symptoms. And healthcare workers with less experience were particularly guilty of this. In one study labeling patients with Parkinson's disease who have masking to have a more negative personality. Another negative consequence of social symptoms in Parkinson's disease is isolation, and this can take the form of self or other-initiated exclusion from social interactions. This can lead to loneliness, which has been shown to have negative health consequences. So in one study, patients who had greater facial masking also reported feeling greater social rejection, and this is demonstrated by this quote. As one patient describes, sometimes you feel that they're looking at you as to say, God, he's a gormless wonder now. So that's what I think they're thinking, and that alters how I feel, which means I'll drift to the back of whatever's happening. And then there's also evidence that healthcare practitioners who interact with elderly patients self-declared that they and their colleagues provide more comprehensive care to the patients that seemed less lonely and had greater social support. So this could feed into a positive feedback loop where experiencing social symptoms leads to stigma and dehumanization, which then leads to feelings of social rejection, withdrawal, and isolation, which then leads providers to provide less comprehensive care, which then worsens the social symptoms, and so on and so forth in a never-ending cycle. And finally, these social symptoms of Parkinson's disease can also have negative consequences for caregivers. So one study found that caregivers who rated their partners to have greater facial masking reported more social rejection, less partner enjoyment, and higher rates of depression. These numbers here are indicative of the strength and the direction of the relationship. And this relationship between facial masking and partner enjoyment in particular even held true when controlling for both patient depression and caregiver depression. As a partner of a patient with Parkinson's disease expressed, it does impact your enjoyment of life because you haven't got somebody who's excited when you're excited or sad when you're sad. You haven't got someone you can share that with. So it does make you sad, which of course detracts from quality of life. So I'm now going to invite my supervisor, Dr. Penny MacDonald, to come up and discuss some of the theories as to why these social symptoms occur and discuss some of the treatments and approaches that can be done to mitigate them.
Okay. All right. Thank you very much, Maggie. All right, so in the second part of the talk, we're going to focus a little bit on the evidence for why these symptoms occur, though that evidence is quite scant. And then we'll talk about some of the things that we can do to address these symptoms, okay? Oh, dear. Better put my glasses on. This is going to be hard doing this. Yeah. All right. So why do these social and emotional symptoms happen in Parkinson's disease? Increasing evidence suggests that the basal ganglia, so the region that is centrally affected in Parkinson's disease, is also implicated in emotion and social processing. So the basal ganglia, shown in red, are a collection of brain cells or neurons that are deep in the brain. These neurons receive and send information from and to the surface neurons of the cortex, which are shown in this diagram in beige. These reciprocal connections between cortex and basal ganglia form circuits. It seems that the neurons in the basal ganglia modulate the functions of the cortex. So in Parkinson's disease, the basal ganglia become increasingly dysfunctional and impairing their ability to modulate functions appropriately and smoothly. The loss of modulatory function of the basal ganglia causes movement problems, dysregulation of autonomic functions, so automatic functions of the body such as blood pressure control or digestive processes, And increasingly, we're recognizing that this modulatory function affects complex deficits in thinking, memory, emotion, and social processing. Okay. This way. All right. This is a bit hard for me. I'm a bit short, so maybe I'm not going to be able to see the screen and my notes simultaneously, so I'm going to go off to this side like this. Okay? All right. So parts of the basal ganglia are affected at different times and to varying extent in Parkinson's, potentially explaining why symptoms seem to appear when they do and to worsen as the disease progresses. So depending on the cortical basal ganglia circuit that's affected and where it is in the brain, different functions will be impacted. So on the screen, you'll see in red the sensory motor circuit. In this circuit that involves some cortex as well as some basal ganglia neurons are involved in regulating movement. In green, we see the circuit that regulates thinking, memory, and decision-making. And finally, in blue, the limbic circuit modulates emotions and feelings. So social functions are among the most complex forms of human behavior. They often require the coordination of all of these basal ganglia cortical circuits to receive and properly interpret sensory information coming from a social interaction, so that would implicate the associative circuit in green, to experience the appropriate emotional reaction to the context involving the limbic circuit, and finally to trigger the response that will give the best outcome, implicating the sensory motor cortex, again shown in red. So through communication among these circuits, the basal ganglia essentially act as an action selector. They integrate various sources of information from the environment, from memory, and learned associations, and they are implicated in choosing the best action program that will lead to the best response. Okay. Using different research techniques to determine when the basal ganglia are engaged and for which functions the basal ganglia are necessary, it's clear that the basal ganglia are particularly involved in processing the emotions of happiness. Okay. The basal ganglia also are strongly implicated in the experience of disgust. And it's theorized that these emotions represent the prototypical approach for happiness and avoid for disgust in helping to select between possible actions. So there's quite a bit of evidence that the basal ganglia are implicated in feelings of happiness. For example, the nucleus accumbens, a portion of the basal ganglia, is known for its role in reward processing and is shown to be increased in activation during the experience of pleasant scenes compared to neutral scenes, as is presented on the screen. So those are your nucleus accumbens that are lit up there. Okay. In another study, thank you, Dorr and colleagues noted the activation of the nucleus accumbens measured with functional MRI increased during positive reappraisals of negative experiences. So this is a process in which patients or participants were asked to focus on the positive aspects of a negative experience to enhance positive feelings, even after something was perceived as being negative. Basal ganglia activation occurred in this circumstance, but did not occur when patients did nothing or when they were asked to minimize their reappraisal. So in this technique, they focused on the non-emotional aspects of the experience to dampen down the negative feelings. All right. And in another study, it was found that happy classical music led to an increased activation in the ventral striatum or the nucleus accumbens compared to neutral music. So based on these and many other studies, it's really clear that the basal ganglia, particularly the ventral portions of the striatum, are implicated in rewarding feelings that are important to the processing of happiness, as well as to the experience of happiness. Given that PD causes basal ganglia to function improperly, it's not surprising that PD patients might have problems processing, judging, and experiencing feelings of happiness. The basal ganglia also seem strongly implicated in processing feelings of disgust. In a study performed by Wagner and colleagues, the volume of the basal ganglia was found to positively correlate with something called the animal reminder disgust propensity, which is a measure of the disgust that an individual experiences would experience for statements such as, "You are going to touch a skull." So the two displays effectively show that as the basal ganglia are bigger, the stronger the feelings of disgust. Okay. In another very interesting study, Roya and colleagues found that in healthy cheese-hating, who are they? I don't know. Cheese-hating people, the degree to which they were disgusted by cheese predicted how active the basal ganglia were while viewing photos of cheese as well as smelling cheese odors. And this study was done using, again, a brain imaging technique called functional MRI. And just make sure it's there. Finally, in another study, Fitzgerald and colleagues found that the basal ganglia are also activated during the recall of disgusting memories, an effect that was not seen during the recall of non-emotional autobiographical memories. Okay. In addition to the association of the basal ganglia with processing of specific emotions such as happiness and disgust, research investigations in healthy participants have implicated the basal ganglia in specific aspects of emotional processing, potential more complex emotional processing, potentially explaining higher order social symptoms that occur in Parkinson's. For example, is that study in there? All right. Simply imagining that you are laughing or crying activates the right putamen and bilateral caudate nuclei, which are both areas of the basal ganglia. Interestingly, this activation, measured again with functional MRI, did not simply occur because patients were imagining motor acts, crying or laughing, because there was no activation in these basal ganglia regions in a control task in which participants were asked to imagine that they were walking. In another study, participants were asked to identify the emotions displayed on a variety of faces while undergoing functional MRI, and it was found that recognition of disgust facial expressions was associated with activity in the right putamen and caudate, again, basal ganglia regions, that whole collection of nuclei, and these, again, are impacted negatively in Parkinson's. And then further corroborating the implication of the basal ganglia in emotion recognition, patients with structural lesions in their basal ganglia, so not Parkinson's patients, but perhaps stroke patients, have emotion comprehension deficits as well. Oh dear. Yeah. All right. And finally, there's also evidence of basal ganglia activation during speech prosody recognition. And Maggie gave you a great demonstration of how prosody and intonation can impact judgment the same word being stated in different contexts. So in this recent study, it was found that increased activation in the external globus pallidus and the putamen, components of the basal ganglia, was elevated during listening to happy voices compared to neutral ones. Now, as Maggie mentioned previously, patients with Parkinson's disease experience, so kind of moving along from these the more social symptoms, we're going to get into affective symptoms, which also impact social function and social interaction. And as Maggie mentioned in the first part of the talk, patients with Parkinson's disease have higher rates of depression and anxiety than do patients with other chronic diseases that cause similar rates of dysfunction. In this way, depression and anxiety, like the motor symptoms that occur in Parkinson's disease, are thought to be caused by the neurochemical disturbances that occur in Parkinson's rather than to a reaction to these illnesses. Although Parkinson's disease is associated primarily with degeneration of dopaminergic neurons, shown in blue in the diagram, sorry, this back and forth is making it a little bit difficult. Depression and anxiety also seem to be mediated by serotonin, another neurochemical that is impacted in Parkinson's, and that's shown in red. Going along with this, serotonin seems to be a key in maintaining balanced mood and avoiding depression and anxiety. And as a consequence, selective serotonin reuptake inhibitors, or SSRIs, are the main treatments of depression and anxiety in both PD patients and non-Parkinson's patients. It's likely, though, that dopamine and serotonin levels combine to determine the emotional state of healthy people, as well as in patients with Parkinson's disease. Depression and anxiety are correlated with the degree of dopamine neuron loss in Parkinson's. Further supporting this, patients on dopamine agonists show improvements in their anxiety and their depression. And finally, patients undergoing dopamine withdrawal experiences generally experience anxiety, depression, as well as pain and fatigue. So again, suggesting that the removal of the external dopamine can exacerbate these symptoms. Oops, back that up. Okay. Apathy is the least well-studied and understood neuropsychiatric symptom of PD. There is evidence that in the early stages of Parkinson's, serotonin neuron degeneration is associated with apathy. However, later in the disease, dopamine degeneration appears to contribute more to the presence and the severity of apathy. So now, shifting gears a little, what can be done to alleviate these symptoms? Unfortunately, for most of these social symptoms, there are no direct treatments. This is in no small part due to the fact that we're just beginning to recognize and understand them. Behavioral speech therapy has been shown effective treatment for dysphonia or quiet speech, and to a lesser extent in treating dysarthria or problems with speech articulation. And these are both symptoms that adversely impact social interactions in Parkinson's. The Lee-Silverman voice treatment, or LSVT Loud, is a speech treatment with level 1 evidence for improving vocal function in Parkinson's disease. Briefly, this treatment involves improving speech volume and voice box strengthening through frequent practice and sensory feedback recalibration exercises to enhance the projection of the voice. In a recent study, LSVT loud treatment increased communication, participation, and effectiveness in patients with Parkinson's disease when measured immediately as well as immediately prior to treatment, as well as 1 month and 7 months follow-up. And that's shown in blue, and you can see that the gains were maintained for 7 months. Patients increased their tendency to ask questions, as well as to give detailed information in conversations. Patients also showed improvements in their abilities to have conversations at home in both quiet and loud settings, and as well as at a distance. And that's shown in pink, showing similar levels of maintained benefits from participating in this. However, the efficacy of LSVT loud treatment tends to wane at long-term follow-ups. So the cost of this treatment should be considered when thinking about prescribing it, and further study is required to determine the long-term gains of this. And finally, choral singing programs have also shown some positive outcomes, including improvements in phonation time, prosody, as well as fatigue. And importantly, this approach also improved mood, and patients and caregivers tended to find this an enjoyable exercise. I guess it would depend on your voice level, how enjoyable that would be, but okay. All right. Interestingly, actually, LVST has been demonstrated to improve facial masking. So in one study, patients with Parkinson's disease demonstrated improved variability and frequency of facial expressions after 1 month of LSVT loud treatment. Notably, patients treated with an articulation training or those who received no treatment at all did not display any of these improvements. Specific rehabilitation programs have also been tested, with some showing more promise than others. For example, rehabilitation programs that incorporate a focus on proprioception, so a person's ability to sense his or her own body and body position in space, and practicing emotion recognition appear to improve facial masking symptoms compared to simple facial muscle exercises or to no treatment at all. And again, with those rehabilitation programs, the long-term gains, it's not clear. The studies haven't followed them out significantly. And finally, awareness of these symptoms alone seems to go a long way. The simple recognition of masking as a symptom of Parkinson's disease can better enable adjustment to an expressive impairment deficit. On the panel to your right, my left, is a quote from a caregiver in which she expresses guilt over not having recognized a social deficit which led to inappropriate responses to her partner due to this lack of awareness. Along these lines, patient and caregiver education has been shown to reduce patient and caregiver depression. One study implemented an education program over a series of 8 weekly sessions of 90-minute duration. This program was designed to help patients and caregivers understand, manage, and cope with their symptoms. At the end of each session, both patients and caregivers experienced a significant improvement in mood. Okay. At the end of the full 8 weeks, caregivers reported being less bothered by their partner's achievement capability and reported needing less help to provide care. 90% of patients and caregivers agreed that the program was helpful. The majority of them said that it improved their understanding of Parkinson's disease and the social symptoms, and they felt that they could better deal with these symptoms of the disease after the training. And finally, another study suggests that caregivers with greater social support networks, such as those who are involved in support groups, experience less caregiver loneliness. Okay. In terms of treatments of neuropsychiatric symptoms, thank you for that. Depression can be improved with cognitive behavioral therapy. And both depression and anxiety are well treated with selective serotonin reuptake inhibitors in several studies and in many meta-analyses. Dopaminergic medication hasn't clearly shown improvements in most of these social symptoms. Nonetheless, some patients do feel that it might help, and they're more inclined to take extra dopaminergic therapy when they're about to enter into a social setting. The evidence at the moment doesn't suggest that this is advised, as it does have some side effects, as most of you in this room are aware. Increasing doses of medication are associated with side effects such as dyskinesia and some psychiatric symptoms like hallucinations. So in conclusion, there's ample evidence that Parkinson's disease involves social symptoms and that the emergence of these symptoms is common and disruptive to patients' lives, as feelings of stigma, dehumanization, and loneliness might lead patients to withdraw from social situations. These social symptoms might also affect caregivers who experience loneliness due to difficulties relating to their PD counterpart, as well as due to the demands of the caregiver role and the consequences of stigmatization that are related to Parkinson's disease. Unfortunately, these social symptoms are less well recognized by clinicians and researchers. These symptoms impact quality of life disproportionately to other symptoms, and therefore these areas require much more investigation. Just making sure. These social symptoms and their consequences are addressable, but anticipating potential social issues requires, firstly, acknowledging and preparing for them to occur, and secondly, actively re-examining whether social needs are being adequately met as the disease progresses. So keep checking in with these symptoms that might have been addressed at earlier stages. And then finally, as in most other areas of Parkinson's, much more research is needed to understand these complex symptoms and to uncover more effective long-term therapies. And that's it. Thank you.
So thank you both for a very interesting perspective on what can be a very, very difficult situation and for many people's lives. I know I've had to address this in some advocacy issues with people's living situations and so on. So we have 10 minutes for Q&A. And again, we've got Tricia and Madeline roaming with the mics. Just put up your hand.
When you were doing the studies on the facial recognition and the surveys that you did, Maggie, where people thought less of the people with Parkinson's, were they aware that they had any kind of physical conditions?
So it depends on the study, but in most of those studies where participants are shown many different videos or voice clips, they're not aware of the diagnosis of the patient or whether it's a healthy control in those studies. So yeah, that's a good question. So even without knowing, they're picking up on greater facial masking and then making these more negative impressions of the patients.
I found in my, one more part. I was just saying, I found in my groups that people are split between not wanting people to know they have Parkinson's and then advertising that they have Parkinson's. And I wonder if the stigma is worse in people who don't share that they have Parkinson's because they're probably judged more, personally rather than recognizing the condition. Did you find that? Or?
Yeah, so in the qualitative research studies that I've looked at, so for example, like I showed a lot of quotes from patient interviews. In those types of studies, patients do report, hesitation to let others know that they do have Parkinson's, but in general, it does seem to help because it helps other people, recognize it's not the person, it's their Parkinson's, right? And so it helps kind of shift those, negative impressions or negative feelings toward a person, off of the person themselves and onto the disease, right? It kind of gives an explanation for these things. So from what I've read, it does seem to help, but I do understand that it can be stigmatizing to disclose the diagnosis to others.
I think there's on this side here.
Is there a link between hearing issues and deafness and Parkinson's in terms of these social kind of issues?
Not that I've investigated. I haven't read any studies published on that. Penny, I don't know if you
Just
have
that
any
I know
more.
that if people have difficulty with their hearing, they can become more isolated. They step out of social situations.
Absolutely, yes, yeah. And so that's something that, is probably more generalized than specifically with patients with Parkinson's disease. But yes, people with, hearing loss in the general population probably do experience these things like withdrawal and social isolation and loneliness. So that's kind of, I think, its own body of literature, which I personally haven't looked too much into, but you're absolutely right. These types of negative consequences aren't limited to the experience of patients with Parkinson's.
Parkinson's make it worse.
I don't know. I mean, I'm not aware of studies specifically that have investigated that, but I think it stands to reason that there's likely an interaction. So in the general population, hearing loss can be quite isolating and also taxing for cognitive processing. And in Parkinson's disease, where you already have this one other layer of social exclusion, either self-imposed or because others are interacting with you in a more negative way, the overlaying hearing impairments I would expect, but I'm not referencing a specific study.
There's one here in the middle. You can have a microphone. Oh, I'm sorry, sir. There's one over here.
I'm struggling with language, healthy versus Parkinson's patient. I'm a caregiver, so I assume I would be viewed as healthy in your study, but I have my own various diagnoses and disabilities I identify as disabled, and so I'm struggling with that kind of language. And I wonder whether when you talk about Parkinson's patients, and I look around the room, and we've got, 100, 120 to 150 people with Parkinson's in the room, I don't see any patients here. I see people who got their asses out of bed, who got here by 9 o'clock, and who are sitting for all these hours, which is hard on my back. I've got my pillow here to help me. So it's not a question, it's a challenge, and it's a wonder whether that kind of language further dehumanizes an impairment that already is being dehumanized by society. So I'm just going to throw that out there to the medical field and the research field to carefully look at language, because I don't see patients in the room.
Yeah, you're absolutely right. We're always very, cognizant of that, or try to be, in our research lab especially. We really try to never use the words Parkinson's disease patient and refer to, or subjects. Yeah, subjects is an awful word. So yeah, we're sensitive to that and try to use more person-based language, but you're absolutely right. It does contribute to the dehumanization aspect for sure.
Let's let Dr. Fasano have a word. Please just join with me in thanking both of them again. And we have a very small kind of gift certificate. Thank you all for being here today.